So we are recording this session for the purpose of documentation and dissemination post the conference. So please do let us know by chat if you would not like to be recorded or quoted. We'll keep that in mind. In the interest of taking active consent, we will be removing all AI note-taking assistants from joining the call. Ayushi, may I please request you to just have a look at the participant list and see if there are any already in the room, and if they are, please just remove them. To save bandwidth on this call, please do turn off your camera and keep yourself on mute while you're not speaking. And we can speak in Hindi or English based on your comfort. So feel free to ask questions or make comments in either of those two languages. And in case anyone needs any sort of assistance, feel free to reach out to any of us from the CoreNet team. We'd be happy to help with translation. Please do use the chat box and leave your comments and questions, and try not to interrupt the speaker during their presentation. And it would be great if you could introduce yourself and your organization along with your comment or your question, so it's easier to maybe respond to you and contextualize where you might be coming from. Also, please do keep in mind the time. Sessions have been programmed in parallel, so in case we do run over, that does actually disrupt the rest of the programming. So we'll please try and be very strict to keeping to time. So just a quick look at the agenda. We're at the 5 minutes introduction, after which I'll hand it over to the Monk Prayogshala team to take us through their presentation. And we have about 30 minutes for questions, comments, and a very enriching discussion that we hope to have towards the end. And as I mentioned previously, just try to let the team from Monk Prayogshala get through their presentation, and then we can stop and focus on questions and discussions later. And just maybe a quick introduction to CoreNet on the next slide, please. So the COVID Research Network is an effort to build a community of practice to foster exchange and collaboration among research organizations, gathering information on issues relevant to COVID-19 pandemic in India. And the CoreNet Secretariat is being anchored by Quicksand and supported by the Bill and Melinda Gates Foundation. After about a year of sort of coming together and setting up this community, we have 56 member organizations working in 23 geographies. If you could just turn to the next slide, please, Aditya. We have 25 individual members on the Slack workspace. We have 87 submitted research projects on the web platform. We've hosted 19 coffee hour sessions within the community, and we've hosted 3 ethics dialogues, and the CoreNet conference seeks to bring together the community and other stakeholders to discuss learnings and experiences for future directions. And that's kind of where we are today. And sort of with that brief introduction and context of the community, I'd like to hand it over to the Monk Prayogshala team, who today we have Hansika and Arathy from their team, who will present their work on conspiratorial theories, moral emotions, and messaging related to COVID-19 in India. So just for a quick introduction to Hansika and Arathy. Hansika holds a PhD from IIT Bombay in the area of creativity, specifically negative creativity, which means how people get good ideas to do bad things. She's a recipient of the Fulbright Nehru Postdoctoral Research Fellowship of 2019-20 and is an affiliate of the University of Connecticut. She's a published author, practicing psychologist, and visiting faculty in several liberal arts universities across India. And her research interests lie in individual differences, creativity, and behavioral science. Arathy completed her BA in psychology from Xavier's College, Mumbai, and her master's in industrial psychology from the University of Mumbai. She has published work in current psychology and personality and individual differences. Her interests are in evolutionary psychology, social cognition, psychometrics, and decision processes. And with that, I just hand it over to Hansika and Arathy from the Monk Prayogshala team. Thank you.
Thank you so much, Nitya. And we're really happy to obviously be here and be able to share our work via CoreNet, and kudos to everyone in the organizing committee to organize and get together like-minded individuals, and probably even unlike-minded individuals together at the CoreNet conference today and over the next few days. So based on the introduction, Arathy and I will be presenting our work on insights from psychological science during COVID-19 in India. And just to begin, I'm going to spend a couple of minutes introducing our organization. So we are Monk Prayogshala, and we are a not-for-profit academic research organization based out of Mumbai in India. And we primarily do three things. One is the core academic research in primarily the social sciences to begin with. So that includes psychology, sociology, economics, public policy, gender studies, political science, and the like. And a lot of our research, as you would come to know later in the presentation, is very, very interdisciplinary. And we pride ourselves on making sure that none of our projects are well adhere to the tenets of only one specific discipline within the social sciences, because we do believe that there is a lot to learn across disciplinary lines. The second thing that we do is capacity building programs, workshops, training sessions for people ranging from undergraduate students to professors in India and across the world. One of the reasons why we primarily do that is to meet the training gap in research methods or even publication processes or new and upcoming open science practices. So we do try to do that, engage as much as possible with the research community and the social scientific community in India and across the world. And the third thing that we largely do is fundraising and grant writing. So and collaborations with say other non-profit entities or NGOs, or taking up monitoring and evaluation kind of studies for other entities that are possibly doing social good. That's where we come from. And over the years, in September this year, we're going to be around for about 10 years now. So it's been a long journey, and we've made a few friends along the way across the world, thankfully. And we, as I said, we thrive on our network. We thrive on the interdisciplinarity of our network as well. So both within India as well as out of India, we do have several collaborations and several projects that are ongoing in a collective effort to better social science research in India and across the world. As I said, our network also extends to other non-profit entities as well as NGOs, as well as funding organizations that are looking to bring more rigorous research into their practice in some way. And we may engage with any of these organizations from a training perspective, where we go in and help their existing personnel and staff learn more systematic methods to collect data, for instance, or to streamline their data collection processes or their intervention assessment processes, or if they have already collected data in a systematic way, we come in as third-party evaluators, so to speak, to look at the efficacy of their interventions and then write up reports based on the same. Based on resources that we have a wide array of statistical, experimental, and research database tools that we rely on to make sure that the science is as cutting edge as possible, given the constraints that we are operating under. We do have a dedicated and trained team from pedigreed colleges comprising of full-time and part-time research personnel. And although our headquarters is in Powai in Mumbai, we haven't been to office in over a year now. Everybody's working remotely, but we do have an experimental space as well as an office space in Bombay. Considering we do a lot of our research with human participants and with data that could be construed as sensitive in nature, we have very strict processes in terms of intellectual property as well as research data confidentiality. We make sure that research participant data is kept strictly confidential, only privy to the researchers in charge. As far as possible, most of our data collection processes involve non-identifiable data, so we never ask participants to give their email IDs or force them to give their phone numbers, and obviously we do not do anything with email IDs in case they put it up for like a lottery that we would be running, that you can get an Amazon voucher if you complete our survey and put in your email ID. So we also have an FWA approved institutional review board at Monk Prayogshala, where we have engaged with some members at Coornet as well to kind of route your IRB ethical processes and IRB applications in case you are wanting to do research within the Indian context. We do have an internal review committee as well. This is a snapshot of the values that we abide by, and I think it's important to highlight the ninth one, wherein we focus on velocity and not just speed. So we want to move in the right direction, but also move really fast. So we're not, especially in the context of pivoting a lot of our research toward understanding COVID or understanding behavioral psychological aspects of COVID, we did realize that a lot of individuals are publishing very, very quickly, but we were still taking it a little slow to make sure that we're moving in the right direction and not overreaching in terms of what we're doing. So to go back to last year, unfortunately, around March this time, that's when, around March 2020, that's when we obviously were under lockdown and things like that. And people really started getting interested in trying to understand not just the pharmaceutical aspects of COVID or the infectious disease perspectives of COVID, but also the behavioral aspects, because a lot of what was going on then and is going on today involves behavioral changes, habitual changes that you have to adopt in terms of mask wearing or hand washing or social distancing, and all of that involved additional cognitive load. It involved remembering to do these things that we as psychologists found really interesting, and obviously that one thing led to another, and a lot of our nascent projects at that time that we started thinking about, started looking at, okay, what are these factors or what are the variables that may be involved in how individuals are responding to new behavioral guidelines in terms of preventive health behaviors and the like, and is there really a difference between how Indians are reacting to these guidelines versus people across the world, and how can we effectively communicate or frame health messaging in a very, very effective way so that Indians could adhere to these guidelines. So I'm going to now request Arathy to come in and share some of our work that we have done or are in the process of doing in this context.
Thanks. So the first study that I will be discussing, the first and the second study, we collected data in April and early May of 2020, last year. So these two studies were a part of a larger multinational study, and specifically we collected data from India in two languages, English and in Bengali, with a colleague of ours. We studied how conspiratorial blame may have a mediating effect on political ideology and risk perception specifically in India. So what we basically did was measure political ideology using a 10-point rating scale, where 10 means extremely right-leaning or extremely conservative. And then we asked our participants what they thought the source of the virus was. If you remember, there were a lot of conspiracy theories and misinformation about the virus, about the source of the virus across the world, including in India, right? And for example, is this a bioweapon or is this just a flu, and those kinds of things, right? So we basically asked our participants whether and to what extent they believed that one of these parties is to be blamed for the virus: scientists, interest groups, the government in order to cover up an impending economic crisis, or to set up an authoritarian government. Finally, we also asked them to what extent they perceive the virus as a risk to themselves and to others, and to an average person in India. To what extent do they believe that they will contract the virus themselves, and somebody like an average Indian might contract the virus? So what we found here was that political ideology significantly predicted conspiratorial blame, but it did not have a mediating effect in the relationship between ideology and risk perception. What this means basically is that conservatives are likely to blame scientists, interest groups like pharma companies, and they also said that the government is trying to cite the pandemic as a way to cover up the impending economic crash. But blaming the scientists themselves makes you think that you are not at risk of the virus, and blaming the government makes you think that an average Indian is more likely to get the virus. So what this means is basically that
Indians' pandemic response is very different from Americans, whom we compared this to. And we also need to study the social psychology of health-related behaviors in India in like a more stringent manner, which could help us in creating solutions going forward. And this is especially true because there used to be, and there still is, a lot of uncertainty regarding the source of the virus, the consequences of the virus, and what it means and how it spreads and things like that, right? And also it kind of distorts our beliefs about the virus. Now let's look at the next study. Okay, so we use the same sample as the first study and looked at different variables this time. And we wanted to basically answer the question, what predicts COVID compliant behaviors in India or preventative health behaviors in India? We studied specifically policy support, which is basically to what extent are you likely to support, say, shutting down parks or restaurants? Physical hygiene, which is basically, for example, how often do you hand wash? And physical distancing, which is basically I don't meet people I'm not supposed to meet. And we basically studied two predictors in depth: political ideology, which, as I mentioned, is left and right-leaning individuals, and collective narcissism. So collective narcissism is basically believing that your group, in this specific context, your country, India, is special, and also that this specialness is not acknowledged by others. Our idea here was another popular reasoning that we used to have at that time, which is basically that Indians are immune against COVID because of how special we are, or because we have higher immunity, or because of the summer heat and things like that, which, as we know now. We found that political ideology did not have a relationship with compliance behaviors or preventative health behaviors, but collective narcissism did. But what we did find was that the more you thought India was special, the more you were likely to engage in policy support, supporting the policies or physical hygienes and other preventative behaviors. But the effect sizes for these were very small. So then we asked what does affect prevention behaviors, and found that other factors did. For example, moral identity and social belongingness, and some individual factors like self-control or open-mindedness, which kind of makes sense because if you have like higher self-control, you are more likely to support policies, or you're more likely to continue engaging in preventative health behaviors, right? And in the final study, yeah, so this was conducted between September and October of 2020, where the cases were kind of going down because people were really tired of sitting at home and things like that. But people were really tired of sitting at home, but our cases were also going down at this point. So at that time, we wanted to study how message framing might improve preventative health behaviors. We use the same behaviors as before: distancing and policy compliance. What we basically did here was that we had 4 conditions of how the message is framed. Either it focuses on what COVID will do to you, or what COVID will do to a close family member, and a positive versus negative balance, which is basically how, for example, if you wear a mask, you will save yourself from COVID, is basically the positive frame. And if you don't wear a mask, this is what will happen to you, is the negative frame. Then we asked people to rate how they felt after hearing about these symptoms, and we measured. So these emotions that we measured at this point, which is how they felt about hearing these symptoms that you get after getting COVID, are called moral emotions, because they kind of motivate you to engage in morally good behaviors, or they might motivate you to. They are basically linked to our moral and social behaviors, and basically linked to the interest of societies and to human welfare in general. So this includes, say, guilt or shame. And moral emotions can be grouped into 4: self-praising emotions, for example, pride; other praising emotions, for example, awe; self-condemning emotions, which means, for example, guilt; and other condemning emotions, for example, anger. And what we found was that none of the message frames were better than others in terms of affecting preventative behaviors. So what this could mean is that basically any of these frames could work. But what was interesting was that moral emotions affected health behaviors. So each group of moral emotions affected physical contact and policy support. Other condemning behaviors were also predictor of wearing a mask. So what do we do with what we know?
I actually just wanted to add in that, so the questions, the statements technically that we asked for moral emotions were anger towards others who don't wear masks, or pride if I wear a mask, or embarrassment if I don't wear a mask, and things like that. So what we found in this study specifically is that highlighting moral emotions in health messaging was a much better predictor of whether an individual would actually wear a mask or not. And of course, you can understand that within the social context of India, that may have been more safe.
So what will we do with what we know is basically that other than replicating this work in different time contexts, like maybe if we do the study now, we might find other things. We can also do the following, using moral emotions for messaging. So for example, you can have messages like X was proud that they saved lives by wearing a mask, or X was embarrassed because a close relative got COVID or something like that. And you should too, right? But obviously we can't really do this right now in these circumstances, but we definitely have a long road ahead, and we should probably aim to test and use such messages in the future when things are like a little better. We should also use identity-based approaches or identity-based messages. So for example, Indians should try to save other Indians, and we are all on the same boat. Those kinds of messages might help. For example, if you remember, Uddhav Thackeray very recently said that, oh, I'm your family and you should listen to me. Those kind of messages might help, right? We could also use these insights in health-related behaviors, like future health-related behaviors, like probably stopping smoking or something like that. We could also try using these to kind of increase vaccine uptake. Obviously not right now, but in the near future, if that is an issue in the near future, like it was just like last week. So yeah, I think, and we can also use these like to reduce fatigue, which we will obviously in like a couple of months, maybe we might again get tired of sitting at home. So people will start going out or whatever, and you might have to use these kinds of messages to kind of stop. Yeah.
And I think I would just want to add that the salience of moral emotions was something that we hadn't really accounted for or expected. And one of our current projects is also looking at how moral emotions can give us a little more insight about how people think about getting vaccinated or other people getting vaccinated. So in the same way, having sentences like pride if you get vaccinated, or anger towards those who don't get vaccinated, and things like that, coupled with a measure of vaccine hesitancy that we are developing, can give us a little more insight into what are those messages, what is that health related communication that can really push people or encourage people rather to take up the vaccine and things like that. The other thing that we're also doing in terms of future work is trying to understand this trying to understand whether the kinds of information sources that I am using to get information on COVID-19, whether that has an impact on vaccine uptake, vaccine hesitancy, choice of vaccine, Indian vaccine versus another vaccine, and things like that. And the choice of vaccine is, of course, a hypothetical question, because you can't choose which vaccine you're going to get unless you go to a specific hospital that provides that vaccine, that specific type of vaccine. But what we're also trying to understand is the variety of information sources that you are exposed to, how that plays a role in figuring out whether you are hesitant to take the vaccination or whether you are willing to take the vaccine. And I think that that's moving in a pretty important direction, given the directive that everyone over 18 is going to now be eligible from May 1st onwards. So it is also important to understand what the motivations are for people who are actively looking forward to getting a vaccination versus individuals who probably are still a little skeptical about whether they want to do this. That was our presentation. Actually, that was a snapshot of the work that we're doing at Prayogshala. Of course, there are other COVID-related projects that are not necessarily at the individual level, but more at the like comparing countries or comparing country-level behaviors versus individuals. But we wanted to present something that is centric to Indian participants and the data that we've collected in the past about this.
Great. Thank you so much, Arathy and Hansika. This was incredibly fascinating to hear about the kind of work that you're doing, and as well as I think some of the work that's more in the pipeline. So maybe I'll just pause and just see if there are any questions from the audience. I do have a question for you, but I'll hold on to that and maybe see if anyone else would like to go first. Feel free to kind of unmute yourself, turn on your video and ask your question, but also feel free to write your question out in the chat if you're unable to do so. Okay, so Rishabh's question is, are there any thoughts on the communication from our politicians during this period?
Thank you. I think in terms of communication, there is a vast amount of research related to health-related communication at times like these, and I think anyone in a position of power, anyone with the ability to influence other people's behaviors it may be best if they take a leaf out of um, like academically sound communications. I suppose, like AR was saying, there could be identity related communications in India specifically, that we are all a family, and like basically priming or bringing to mind the collectivistic nature that we have, that can be a little more beneficial. That listen, if you take a vaccine, you're not just protecting yourself, you're protecting your family, you're protecting your neighborhood and things like that. So your moral circle of responsibility is expanding by virtue of you taking the right steps. So I don't have any comment on that either, but I would say that anyone in a position of power to influence other people could do more evidence-based health communication.
I think we have quite a few questions coming in. There's one question from Nigel Brankin, who's asked, could you perhaps share what drives moral emotions?
Sorry, perhaps I could just ask a little bit more about it. Yeah, I'm just curious. I mean, how is that formed? The moral emotions, what is it linked to? Yeah. So, can you also give some example of some of the moral emotional messaging that you're talking about? And is that linked to just general social pressure? How does that get formed and shaped?
So basically, we took moral emotions from Haig's theory about moral emotions, basically. So, for example, like an other condemning emotions would, like what would drive an other condemning emotion is basically, say, for example, punishment, like antisocial punishment or like pro-social punishment or cooperation. And basically, it's coming from like a point of driving like social behaviors or our social relationships.
Sure.
I could add in more, and I mean, so moral emotions may, as Arathy was saying, come from a place of kind of governing the social order, or just making sure that you have norms of cooperation and punishment that are not to be violated. So if I hold mask wearing really important to me, then I'm more likely to say that I'm very angry towards, or I hold a lot of contempt towards someone who does not wear masks. So it kind of comes from a place where what is valuable to you from a moral standpoint, that I'm wearing a mask because I'm protecting the people around me and I'm protecting myself, and it's the right thing to do. And if you see someone else violating that behavior, then you experience a moral emotion toward them. And similarly, if you're behaving in line with that behavior, you experience a positive moral emotion toward yourself. But it is we subscribe to Haig's theory of moral emotions. That's I can type it out in the chat and probably put in a link as well. Hope that.
Thank you.
Thank you. I'm so sorry. I realized that maybe I should be asking people to sort of introduce themselves when they ask a question. So it might be nice to have a sense of what kinds of profiles are in the room. So Nigel, if you'd just like to maybe take a minute and introduce yourself. I'm sorry, I forgot to mention that previously.
I'm Nigel Brankin. I'm from South Africa, and we have the privilege of working with Quicksand on a project together, looking at how do we amplify resilient communities, which is funded by the Bill and Melinda Gates Foundation. Yeah, and just very curious about this subject. It's so grateful to be part of this. Thank you so much.
Thank you, Nigel. We have Devanshi, if you're here. Sorry, no, I think Muskan had a few questions before that. Muskan, if you would like to unmute yourself, introduce yourself, and ask your questions, that would be great.
Yes, hi. I'm a final year student at the Symbiosis School for Liberal Arts, studying psychology, economics, and political science. I'm actually in the process of writing a dissertation on why do people believe in misinformation about COVID-19. So these presentations have been really helpful for me. And I have a few questions that I would like to ask, if that's okay. Can I ask all three? Okay. So the first question is, so have you borrowed from the health belief model in your work, which basically talks about how perceived risk, perceived susceptibility, and self-efficacy to carry out compliance behaviors kind of affect your actually doing them? The second question is, would there be a difference if, suppose I use a 10-point scale you used to measure political conservatism or liberalism versus if I use a scale like the one Monk Prayogshala prepared on Indian political ideology? How would that kind of impact my work? And is it the same if I'm looking at political ideology versus political liberalism and conservatism, especially in an Indian context? Then the third question is, I just want to know more about the statistical methods that you used to arrive at your results, especially about the compliance to preventative COVID behaviors and the personality factors, or was it done in a kind of a multiple regression kind of way, and or followed by t-tests and significance testing? And yeah, so basically those are the three questions. I'm sorry if this took a while.
No, that's perfectly fine. Thank you, Muskan, for that. I'm going to let Arathy get the second two because she's the one more proficient in political ideology and spearheaded developing an Indian political ideology scale at Monk. In terms of the health belief model, I don't think we very explicitly use that structure to motivate our projects. However, we do understand, because a lot of our projects involve risk perception or involve understanding how risk perception can therefore, or rather how risk perception can lead to engaging in preventive health behaviors. I suppose at a more latent level, it does subscribe to that, but I don't think it was explicitly formulated within that structure. And Arathy, if you could get to the other two questions.
Yeah, and also in addition, I mean, we did kind of refer to health belief model while doing the health communication study, but it was mostly driven by like emotions as risk model. I think Lowenstein, I want to say, I'm not sure if that's how you pronounce it. And once again, I'm just gonna read the second question again. Oh, okay. So I think you asked whether a single item question versus a longer thing would kind of, yeah, I think it would kind of make a difference. But the thing was that the study that we did, like the first couple of studies, was a part of a larger multinational kind of a study, which meant that we really could not focus on just India. And we also were kind of limited by time, in the sense that the study in itself was going on, I think, like 40-45 minutes. So we couldn't really do like a really nitty-gritty long questionnaire, long scale kind of method there. But yeah, I think there might be a difference, because what we do find in India very interestingly is that people are not very, like, I'm not sure if people understand exactly what you mean by left versus right. So there is a difference between like political elites and like non-elites with respect to their political behaviors, with respect to how they rate themselves and things like that as well, right? So I mean, this could go on for a really long time if I try to answer it, but I hope I answered that.
Okay. Yes, that was helpful. Thank you.
Yeah. And with respect to the stats, we use mediations mostly, but it kind of does follow like a multiple regression. Yeah. Right.
Thank you. And sorry, but can you just adding to the last question about the stats? How do you kind of rise above the whole, this is actually a correlation and not a causation kind of a study? I mean, of course, significance testing, but still some people might kind of bring up the criticism that all of your work is correlational. Is it enough to say that, oh, mine is actually an exploratory study? So I'm just trying to figure out what variables work, especially because such studies are really not done in an Indian context, so to speak.
So it's a really interesting question, but I would also, so for example, in the second study, we used a mediation model, but it was an experiment in the sense that we used 4 different, so it's coming from a research design point of view, right? Like eventually every statistic is a form of regression. If you want to, I mean, you could argue that. So it comes from like whether or not you studied it in terms, like it went from the research design, right? So the second study was specifically experimental, but the first and the second study, or the early April, the larger study was like a correlational study, I guess you could say that. And what we are not saying is that like this causes this, just that this is a predictor of this, if that makes sense.
Yes, thank you.
Great.
You have anything to add?
Sorry.
I mean, I'm going to be a very tough psychologist here and say that causality can only be determined through running experiments. But regressions of qualified causality, and I mean, I don't think it's only it is associational. So I think it's how much it's the extent to which you say that, okay, this causes this, or this is predicted by this, versus this is associated by this in a positive way or in a negative way, that kind of thing. So the language that you're using can also indicate the level to which you yourself believe in the determinism of a regression versus an experiment in that sense. So I think that, I hope that also helped in some way.
Yes, thank you so much. And can you have put my email ID in the chat box, if you could please send the scoring criteria for the Indian ideology scale, or if that's possible at all.
Yeah, absolutely. We'll do that post this call immediately.
Great.
Thank you.
Thanks, Muskan. I think those questions were helpful for some of us as well, even though I think some of the terms are a little technical. It was interesting to see how you broke that down. I actually had one question. I'm just going to ask it since I see there are no other questions in the chat. I found what you talked about collective narcissism very, very interesting. And I had sort of maybe 2 questions on that point, because I don't think I'm very well versed with what that might be. The first one is that only collective narcissism, is it only related to your country? Because you said that we think as Indians we're special and we have like immunity as Indians, or can collective narcissism also be applied to like a smaller community? So maybe like your immediate environment, or like a socio-political kind of a community. Like, do you think there's some sort of collective narcissism that exists on a smaller scale? And the second question is just about, I think, identifying that. Is that some collective narcissism? Is it identified retrospectively? Because now, after like 8 months, we know that, oh, that was actually not true. We don't have better immunity. The summer months are not actually going to help us survive this virus or anything. So is that always retrospectively identified, or is it when we were actually feeling those things as Indians, can that be identified as collective narcissism?
Yeah. So collective narcissism it could be group-based. It is group-based, but we studied it with respect to India in the study that we were talking about. That is the only difference. Otherwise, it could be anything. It could be any group that you believe is like a really huge part of your identity. Yeah. And yeah, it's superior. And with respect to the second question, so collective narcissism is kind of like a trait behavior, if that makes sense, which is basically, it's like a general behavior, general belief. So basically you in general believe that India is special, and therefore it applies in like all these different contexts, including you having like a lot of immunity to fight the virus. So it's not necessarily retrospective. I think that is the basic answer to that.
And if I could add that, I mean, for it to be, retrospective, as Arathy said, it could be an unchanging belief, but say, for instance, someone who believed in April 2020 that Indians are special and we have special immunity against this virus, even today, based on, say, COVID numbers, an individual would assume that you would update that belief, but then there would also be some individuals who do not update that belief based on evidence from reality, etc. So, I mean, you can consider that to be also an indication of still belief that, okay, Indians are special, or where the death rate is not as high here, and therefore, so identifying like some level of contradiction to even like fact is something that perhaps drives this rigidity in belief, or non-changing belief, I suppose.
Great. Thank you for answering that question. I see we have one question from Devanshi. Devanshi, would you like to unmute yourself, introduce yourself, and follow up your question?
Sure.
Yeah, great.
Sure. Hi everyone. Thank you so much, Hansika and Arathy, for sharing the amazing research that you guys have done. I am Devanshi Syare from Tinker Labs. I'm a senior design strategist here, and we are basically an innovation consultancy using design thinking and behavioral science to basically solve complex social issues. We've been working in the sectors of public health, sexual and reproductive health, to be specific, tuberculosis, education, and also water and hygiene. So my question, actually, I really wanted to understand what kind of questions or what kind of things went into the design research, especially in the case of the second study, the collective narcissist one, and what kind of data did you have to synthesize to get to the finding that collective narcissists display greater policy support in physical hygiene. So one is that question, where I really wanted to understand the mechanics of what went behind the research and the synthesis. And the second question that I have was actually, the third one is quite interesting, where messaging framework did not affect the behavior, but moral emotions did. And I was wondering if we have any sort of any emotion buckets that are faring, they are much better in driving action versus the others. So yeah, those are my questions.
In terms of, say, the design that was used for the second study, the collective narcissist one, that was part of a larger data set that was collected across several countries, I believe. And this was just like the variables that we included in our study were a subset of a large number of variables that were collected from this larger data set. So in terms of design, it was a survey-based design. So because COVID, and it was circulated across adult participants in several countries across the globe. And we do have, so we have information from India, and we're trying to also bring in data from another Southeast Asian country, I think Bangladesh specifically, to understand whether these differences hold consistent in this part of the world, so to speak, versus weird nations or Western nations in that sense. So that was the design. And in terms of buckets of moral emotions, I know that the results that we found were for all four buckets, right? Self-condemning, self-praising, other condemning, other praising, everything was significant. So there wasn't necessarily any incremental, like any difference incrementally that, okay, these kinds of moral emotions are more likely to influence change in action. It turns out it was all of them in India. So AR, anything?
I just wanted to point out that we did not find that the messages were not effective. We just found that all the messages, like there were no significant differences between the messages. So it could be that all messages were equally effective.
Great. Thank you, everyone, for sort of asking your questions and kind of engaging in this rich discussion. I'm sure many of us who are also just listening in have learned quite a bit. So just wait to see if we have maybe one final question from anyone in the audience, or even Hansika, Arathy, if you'd like to maybe make like a concluding comment or share something before we end the session.
I suppose right now, where, as you can understand, a lot of people are pivoting research again to COVID-19, and this is the second wave of our research here as well, and it's more focused on vaccine uptake, vaccine hesitancy, and things like that. So I suppose the way what we're trying to do moving forward is use all of the insights that we have gained from understanding whether people would engage in preventive health behaviors, and trying to apply that to whether they would engage in the behavior of taking up a vaccine, because that is also a kind of preventive health behavior. And I see that Muskan's hand is up actually, so I'll give her a chance.
Hi, sorry, because you brought up the topic of vaccine hesitancy. I just wanted to ask, what factors do you think would kind of predict or be associated with vaccine hesitancy? Would something like belief in misinformation perhaps be a predictor, or maybe even political trust in the government or things, or maybe
Thanks so much, Muskan. Great question. So we are in the process, as I said, of collecting data on this, and institutional trust is one of the variables that we are looking at in terms of whether an individual decides to take the vaccine in India. We are also looking at there's institutional trust, as I said, there's also moral emotions. We are also looking at, there's some preliminary work that we've done in terms of vaccine hesitancy to look at whether concerns about the cost of the vaccine, the side effects from the vaccine, as well as concerns about the ingredients that go into the vaccine impacts whether you are going to hesitate to take the vaccine or not. And that actually draws on something called the Purity Foundation. Like, it's a moral foundation of purity that if I'm high on this foundation, then I associate myself with things that are pure and unadulterated and normative in that sense, as opposed to things that could be conceived to be dirty in my perspective. And I'm not necessarily talking about only physical hygiene and cleanliness, but rather about even social norms, or if I perceive certain types of people to be dirty, etc., I don't want to associate with them. So we're kind of drawing on that literature about the Purity Foundation to understand whether vaccine hesitancy may even come from, oh, am I ingesting something impure, or I'm concerned about the ingredients of the vaccine, which is why I'm not taking the vaccine. So multiple things we're actually kind of trying to fit, as you said, all of these things may be included and may be important as determinants, but preliminarily we haven't, we're still collecting data, so it's too soon to tell. But definitely information sources, institutional trust, and just general concerns about components of the vaccine are on our radar.
Thank you so much.
Right, and Hansika, just correct me if I'm wrong, but you will be presenting some of your vaccine hesitancy work on the 30th of April. So anyone who finds that topic incredibly fascinating, be sure to sort of sign up for the dialogue on the 30th of April. If you just look at the CORNET schedule, you'll be able to find it there. And yeah, I'd just like to say a big thank you to Arathy and Hansika for being so patient and kind of sharing such exciting work with us. You could tell by, I think, just the number of questions pouring in. This was very, very exciting to many of us. I'd just like to maybe end the session with a few pointers for you to keep in mind. We do have sort of sessions going on for the rest of the days of the conference. Today is the first day. We have sessions organized tomorrow as well. And then the other 2 days are the 29th and 30th, which is the Thursday and Friday of next week. So do join us for plenary showcases, dialogues through the coming days, and be sure to kind of keep an eye out for the schedule, where things will constantly be updating. Also, given just the nature of how unpredictable things are, new sessions are coming in last minute. Sessions are changing shape and form, so do keep an eye out for those last minute updates as well. And of course, for more details about the community, about CORNET as a community, please do visit our website. I'll just request my colleague Rohan to just put in the website details in the chat if you'd like to directly just check it out right now. And you can also follow us on Twitter, which is @CORNET_India. And of course, if you'd like to join the community of practice and know more about the kind of work that we're doing, feel free to write us an email at hello@cornet.in. And yeah, we just look forward to seeing many more of you at the rest of our sessions. And thank you again, once again, to Hansika and Arathy and the whole Monk Prayogshala team, who's been really supportive and great to kind of plan this session with. Thank you.